Thank you, sir. I would like to request Dr. B.P. Pandey, sir, and renowned interventional cardiologist to please be there on the stage to chair the next session. The speaker will be Dr. Dhiman Kahali, one of the senior most interventional cardiologists associated with B.M. Birla Heart Research Institute and the director of interventional cardiology. He will guide us on renin-angiotensin-aldosterone system inhibitor are known to improve outcomes in patients who have heart failure with reduced ejection fraction, hyperkalemia, and importance of RAASi optimization. And the another speaker will be Dr. Mridul Bera, the backbone of Howrah Diabetic Society, eminent consultant and endocrinologist. Sir, please be there and introduce our speaker. We have another chairperson with us, Dr. Arindam Noshkar, one of the senior most consultant endocrinologist in charge Department of Endocrine School of Tropical Medicine, Kolkata. I'd like to request Dr. Arindam Noshkar to please be there.
So, welcome Dr. Kahali. Please start your presentation.
Thank you very much, Bijay. Thanks, Mridul. He's very friendly, my student, you can tell, and Arindam. Thank you very much, Dr. Munnalal. We are thankful to you for calling me on the occasion. Today, we are going to talk about a very important subject, which is none other than hyperkalemia and the importance of RAASi optimization. Because, just to set the preamble, you should tell, that we give ARNI right and left to our heart failure patients. We give SC inhibitors post-MI with heart failure patient. We give ARBs to control hypertension in heart failure. So always we are giving AC inhibitors, ARBs, and also ARNIs. But unfortunately, in about 30 to 40% of our patients, we have either to down titrate the dose of RAASi or we have to totally withdraw it. So we know that this RAASi, we don't give it unnecessarily, not only to control the heart failure, or to protect the kidneys, or to reduce the blood pressure, or to treat the heart failure with reduced ejection fraction, or mid ejection fraction, or improved ejection fraction, or even HEPEF, that is heart failure with preserved ejection fraction. So we know these are extremely valuable group of drugs and we have to use it. But unfortunately, we have to reduce the dosage, and in extreme cases, we have to stop the molecules. And that is extremely unfortunate for the patient. But in abroad, suppose in UK and European countries, even in USA, now one molecule is available by AstraZeneca, and the name is Localma, and it is a sodium zirconium, and it reduces the potassium, though it is not very palatable, I tell you at the onset, and has few side effects like bloating, gas, gaseous distension, etc., some abdominal discomfort. But ultimately, it's a good molecule, and therefore, they tell it as this may be the fifth pillar or foundation therapy. Though people don't agree with it, there are 4 foundation therapies in treating HEF-REP patients, but it is an extremely valuable molecule for the treatment of cardiometabolic syndrome who are more prone to hyperkalemia. Now, this is the normal serum level, 3.5 to 5, but we must know a basic fact that everything is not normal. I have seen patients with a potassium of 3.5 getting intractable ventricular tachycardia, sometimes ventricular fibrillation. And it was so difficult. The patient has been shocked already. So I saw the blood gas, and it was something 2.8. That means we add normally 0.7, 0.8. And it becomes 3.5, but the patient was getting intractable ventricular arrhythmia, had to be shocked a few times. So just I asked them to correct it. Already they have started it, and by correction of the potassium, we could avoid the arrhythmias. It's possible, very much possible, and sometimes unnecessary ICD or CRTD implantation is also avoided by treating this hypokalemia. And just to give the figures, I would refer to OP's textbook. that if somebody has a blood potassium of 3.8 and another person has 4.5, the person who has 3.8 has 400% increased mortality in comparison to one who is having 3.8. So that is the basic thing. Though we tell that normal range is 3.5 to 5, in some textbook you would find it to be 3.8 to 5, and hypokalemia is defined as below 3.5 or sometimes below 3.8. The decrease in serum potassium may be due to different reasons. You can teach me about that. And these are the cardiorenal patients are at an increased risk of hyperkalemia. And in the general population, its incidence is 2 to 3%. You see the advanced stages of CKD, especially the diabetic patient on RAASi therapy, the incidence is about 40 to 50%. So half of the patient is CKD patients with diabetes and on RAASi therapy. Severe heart failure on spironolactone, not only 50, sometimes 25 milligrams of spironolactone, 40% of the patient develop hyperkalemia. And hemodialysis patients, they also develop 25% on hemodialysis. And diabetes over 3-year period without any exciting factor, they develop in 17% of the cases. And resistant hypertension, the fourth drug is spironolactone. Sometimes we give it, though it's not very effective in Indian population, but we do use in resistant hypertension patient. I'm not going to define it. You know better than me again. And that sometimes causes, because those patients get some ARV, some ACEI, etc., and addition of spironolactone, despite having chlorthalidone as the third molecule, sometimes causes increase in potassium level. Now, you see the incidence and serious clinical implications. Risk for death in CKD, non-dialysis in patients with potassium more than 5.5, this is 5 times higher. And next one, you see, if it is more than 6, it is 16 times higher. And if risk for death in acute myocardial infarction patient, in patients with potassium 5 to 5.5 is higher, 5 times higher, and in patients with potassium more than 5.5, it is 12 times higher. Of course, we have got so many ways to reduce the potassium, because we haven't got Localma, though it is available in UK and other European countries for the last 4.5 years, but unfortunately we haven't got Localma here. So we have some other tricks, like we reduce the dose or make it alternate day, these MRAs. Eplerenone is little lighter than the spironolactone, and we give furosemide instead of torsemide. These are some of the tricks which have some action, we believe, and we reduce the dose of RNA or the ACEI. In this way, we control the dreaded hyperkalemia. Hyperkalemia risk increases also with CKD severity. You see, in CKD stage 4, it is sometimes 5.9, odds ratio of potassium more than 5.5, and it's 11 if it is stage 5 CKD. And in the 1 or 2, it's much less. Now, hyperkalemia associated risk of hospitalization increased in cardiorenal patients again. The 6-month hospitalization risk after index death was 3.8 times higher, with hazard ratio of 3.78 in patients without CKD and hyperkalemia, and in patients with 2 point in heart failure with hyperkalemia, it is 2.8 times higher, and the hazard ratio is 2.75. So you can see the hazard ratio is so high that indicates that these patients are really at a very difficult situation in patients with HF and hyperkalemia. Whatever HF is, it is HF, PF, MIDF, etc., compared to matched patients with CKD oblique heart failure without hyperkalemia. Their hazard ratio is very high. Risk of further hyperkalemia event is common in patients with CKD with successively shorter time between each episode. And you see the hyperkalemia assessed in a northern Denmark population between 2000 and 2012 with incident CKD diagnosis in 1,60,000 odd patients approximately. You see, patients with CKD who experienced hyperkalemia, you see the first event 27.5 days, and then it is increased to 7.68 months. 43 is the incidence event rate, and then it becomes increased to 57 third event, and the fourth event it is as high as 65. So very high hazards, and this is the RAASi usage. Hyperkalemia is increased in patients with cardiorenal disease taking RAASi therapy. No CKD, the incidence of hyperkalemia, as I told you, is very small, 9%. Stage 3, it increases to 21%, and see in stage 4 and 5, almost 40 and 60%. An incidence of hyperkalemia more than 5.5 in patients on RAASi, the no CKD, it is 2.3 hazard ratio, and it is 7.67 adjusted rate per 100 patient months, and it is statistically highly significant between the two entities. Patients who discontinue or receive suboptimal RAASi have worse outcomes. Percentage of patients with adverse outcomes or mortality by RAASi dose, you can see CKD stages 3 and 4, 43,000, huge patient population. And any comments? 43,000 odd patients, and heart failure 20,500 patient, diabetic 79,000 patient, huge population, and total population was 2 lakhs plus across the categories. And you can see the maximum dose, sub-maximal dose, and discontinued, and the blue color is maximum. See, the black is not more. Majority were suboptimal dose because of the associated clinical profiles. Are we really optimally managing patients with hyperkalemia? Change in RAASi, we haven't got any option. We have to reduce the dose of RAASi, means MRA and ACI oblique ARB oblique ARNI. Do nothing or treat hyperkalemia. Now, despite guideline recommendations to optimize RAASi, the majority of patients with CKD and heart failure remain below the target dose because of chronic kidney disease. Patients at target dose 36% of AC inhibitors, and MRA also 36%, and ARB only 3%. And heart failure population, you see ACI only 15% at target dose, MRA is little more 60%, ARB 10%, and ARNI 30%. So that is what statistics tells. Hyperkalemia, so we find that it's a barrier to maximum RAASi dosage, and as we told in the onset, that we have to compromise. We can't give the full protection of RAASi therapy. We don't give RAASi therapy unnecessarily because of the fact that RAASi not only protects the heart, it prevents the heart failure, it prevents the deterioration of LV systolic function. It also is helpful in HAPE population. It is helpful in improved ejection fraction patient. It also protects the kidneys. The nephrologists, if any over here, they know better and can teach me that it's very much nephroprotective. And all of us try to treat this group of patients with, RAASi therapy, and that's very good for the patient. And so you see 38% of the time mild hyperkalemia is there, and 47% of the time moderate to severe hyperkalemia in patients who are treated with maximal dosage of RAASi. Now, these cardiorenal patients reported hyperkalemia recurrences also at successively shorter time intervals. First recurrence, you see 56% of the patient number was 45 days. And then next, after 35 days, second recurrence, 58%. So see, within 4 months or so, the recurrence rate was high as 70%, hyperkalemia. So it's a massive problem, ladies and gentlemen, for all of us. And in another study, patients with HF also had recurrent hyperkalemic evidence at successively shorter time intervals. Hyperkalemia was a barrier to maximum RAASi dose, and RAASi dose changes were associated with doubling of mortality. So if we are talking of the endpoints, the morbidity, it also increases the mortality to 200%. So you can see on the left-hand side change in RAASi dose following a hyperkalemic. Even in patients at maximum RAASi, mortality rates at least doubled in cardiorenal patients whose RAASi was down-titrated or discontinued compared to patients who maintained their maximum dosage. Now, RAASi down titration and discontinuation was associated with increased risk of morbidity in cardiorenal patients, risk of the composite outcome of progression to ESKD and HF-related hospitalization, 55% increased risk of RAASi discontinuation, and 51% increased risk with RAASi down titration. You can see the chart and you can see the Kaplan-Meier risk, 95% confidence interval. You can see it significantly in the CKD and HF patient. And not only that, hyperkalemia causes so many problems. Neurologists, it causes periodic paralysis, it causes arrhythmia by QT prolongation, different types of ventricular arrhythmias, and the drug of choice is mexiletine in these cases, apart from lowering the potassium. And in hypokalemic periodic paralysis, if you treat the patient too aggressively, he can develop hypokalemia. You can treat, there is one molecule to treat this group with hypokalemic periodic paralysis. Can you name some of them? Any person, you can name the molecule. It's very interesting. So it's acetazolamide. Acetazolamide is the molecule which is given to this hypokalemic periodic paralysis, but they improve with correction of the potassium, and they causes a lot of, this arrhythmic problem. Even hypokalemia, when it develops Anderson-Tawil syndrome, that's of course a genetic syndrome, but that causes lots of arrhythmias. But anyhow, so what I want to emphasize that this hyperkalemia, it causes increase in event rate by all these, mechanisms. And guidelines emphasize RAASi optimization and hyperkalemia management before down titrating or discontinuing RAASi. Optimize RAASi to highest tolerated dose. Monitor for hyperkalemia. You have to monitor the patient and treat hyperkalemia, which may help enable RAASi therapy. Only after other measures have failed, reduce dose or discontinuation of RAASi therapy. So guideline emphasize optimizing RAASi for patients with CKD and HF is the KDIGO guideline. KDIGO is the chronic kidney disease guideline. It's the international society. ACI or ARB are recommended in adults with diabetes, hypertension, and albuminuria. So these are the three entities where they tell give ACI/ARB. And this medication should be titrated to the highest approved dose that is tolerated. So if you give Ramipril, you should give at least 10 milligrams, if not more. KDIGO 2021, ACEI or ARB should be administered using the highest approved dose that is tolerated to achieve the benefits described, because the proven benefits were achieved in trials using these doses. We give molecules, but we should have to look that whether they reduce the mortality. Like in CBIS-2 heart failure study, the bisoprolol was proven to be superior only at a dose of 10 milligram. But okay, if we are unable, suppose the patient develops bradycardia, with 2.5, some people have a heart rate of 57, 58. We can't give 10 milligram to that patient. We have to be satisfied with that smaller dose only. That's a different situation. Heart failure, 2021 is ESC for the diagnosis and treatment of acute and chronic HF during the pandemic. ACI and MRA are recommended for patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. I think with ACI, it was 21% relative risk reduction of mortality. With aldactone, means spironolactone, in RAAS trial, it was 34% relative risk of mortality. In FEMAS and FSS trial with eplerenone was 15% risk reduction. One was post-MI, but similar risk reduction, relative risk reduction in mortality. Now again, 2022, the American guideline for the management of heart failure. In patients with HFrEF, titration of guideline-directed medication dosing, including RAASi, to achieve target doses showed the efficacy in RCTs is recommended to reduce cardiovascular mortality and HF hospitalization unless not well tolerated, and this is a class 1A indication for the molecules. Now, current treatment options and potassium monitoring. So, what is the status globally? Only few patients are retested following a hyperkalemia episode. Overall cohort see almost 2 lakh patients, 5.8% is the interest. No retest and retest within 14 days of the event. And you see severity of incident hyperkalemia event was significant. 14,000 patients, so almost 7-8% of the patient had potassium 5.5 to 6, and 3,000 patients, that means 1.5% of the patient more than 6 with proper therapy, guideline indicated therapy. Patients with CKD and diabetes receiving RAASi therapy may benefit from a regular potassium monitoring. The risk of hyperkalemia associated adverse outcome, hospitalization, emergency department visits, or death within 24 hours of hyperkalemia diagnosis for patients who were monitored compared with those who were not monitored. Of course, the monitored group have the better outcome in comparison to the non-monitored one. Now, what is the emergency treatment? You know that emergency treatment is very important. You should remember 1, 2, 3, 4 like that. Hyperkalemia treatment, calcium gluconate, it stabilizes the membrane. Onset of action very quickly within 1 to 3 minutes. Efficacy can be monitored with ECG, and dose can be repeated if no changes observed. Some people tell, give only 1 shot of calcium gluconate. That will do for the whole episode. It's not true, I tell you. You see, they have recommended, this is the guideline, and this is the published in peer-reviewed journal. You can see that efficacy can be monitored and dose can be repeated if no changes observed. And short duration of effect, 30 to 60 minutes. Serum potassium level is unaffected. Avoid in patient receiving digoxin, it's dangerous, and risk of hypercalcemia is there. So you should have to take a few blood gases after giving some calcium gluconate. Insulin glucose, potassium redistribution in the intracellular spaces, it doesn't reduce the total potassium. Onset of action very short, 30 minutes, effect 4 to 6 hours. So you should give the potassium and glucose insulin every 4 to 6 hours. Risk of hypoglycemia is there because of insulin, and doesn't reduce total potassium levels but reduce the serum potassium. Again, we give beta-2 adrenergic agonist, potassium redistribution in the intracellular space, onset of action as little as 30 minutes, effect is independent of insulin and aldosterone, and does not reduce total potassium level. Used with caution in ischemic heart disease because they can cause tachycardia and some ischemic changes. Dialysis, potassium is eliminated, onset of action within minutes, effects lasting until the dialysis are no longer. Concentration of potassium in the
Dhimanda, you have to
dialysis
conclude.
can contribute to hyperkalemia. Limitations and complications inherent to each dialysis modality. Almost I have finished. And these are the treatments. You see diuretics, dialysis, as I told, furosemide is very helpful more than torsemide. I can tell you the potassium secretion is more with furosemide, and this one is the last one, potassium binders, Localma, sodium polystyrene sulfonate or sodium zirconium as it's called, and it eliminates the potassium. Onset of action short, 2 hours. Oral therapy, effect may last 4 to 6 hours or longer depending on ongoing potassium intake or cellular redistribution. So Dr. Pandey, who like me can't give RAASi to all the patients, and I think all of you will appreciate that within next 6 months we will be able to give this molecule Localma, but it's not very pleasant, It sometimes causes serious side effects like intestinal perforation, but that very rarely. And it causes some gaseous distension, etc., etc. No consistent evidence of efficacy. Maximum effect 6 hours. Serious GI adverse events reported, including fatal cases of intestinal necrosis and perforation. Caution with sodium loads in patients with congestive heart failure. You should be cautious because this is a sodium containing molecule. Hypertension or edema. These are the 3 precautions appropriate for intermediate or subacute care only. They have not mentioned about the dosage. It is to be given in water, 45 ml, and the first 2 days you give 30 to 40 grams of this sodium zirconate dissolved in water in 2 divided doses, and from third day you give a smaller dose, 10 to 15 or 20 gram according to the necessity. It comes in sachet like potassium binding resins, and low potassium diet is recommended. We should not forget in the fun and fair to have less potassium like dal, fruits, etc. Discontinuation or dose reduction of RAASi therapy, and potassium binder sodium polystyrene sulfonate, and this is the mechanism, and no consistent evidence of efficacy. This is sodium zirconium cyclosilicate, how it looks like, and this is the molecule. It's not a polymer and highly selective for potassium. Sodium with partial action, SZC zirconium, onset of action 1 hour, harmonized trial. This is a small trial, 258 patients only, and it was effective. We haven't got time to discuss in detail normalized serum levels across patient subgroups because it eliminates the potassium unlike the other molecules. CKD 66% patient in this trial population, 36% heart failure, diabetic 2/3 of the patient, and RAASi was used in 70% of the patient. And 88% of receiving SGHC maintained an average serum of less than 5.1, so very effective molecule, and therefore they are therefore calling the fifth pillar of heart failure therapy. Means HEP-REP therapy. Majority of patients continued RAASi while taking SGHC for hyperkalemia. So it's a compliant molecule and people are taking it and is generally well tolerated. Safety is good, but it has got side effects as like any other molecules. And these are the deliver continuity, realize, stabilize CKD with phase 3 trial, dialyze outcomes, phase 3 trial. So these are a few of the trials to treat hyperkalemia. And for rapid potassium reduction and to sustain potassium control, SGHC is the molecule you can consider, will be the first anti-hyperkalemia therapy to deliver data on cardiorenal benefits from the crystallized evidence program. This is another program which is going on. And thank you very much, ladies and gentlemen, for your patient hearing.
Thank you, Dhimanda. Any question from the audience regarding hyperkalemia? Yes, take the microphone.
Nephrology conference.
Take the microphone.
It was being discussed that the patients, CKD5 patients who are getting 3 times per week hemodialysis, the new conception is coming that ARBs should be continued to get the cardiorenal benefits. The conception is changing now. Those patients who are on maintenance hemodialysis 3 times per week.
Yeah, there is a consensus. Those patients who are on dialysis, ARBs for that matter, we also continue ARNI. So any experience, it is not available so far. I think Astra will launch shortly. Any experience from your friend how it works, how quickly it works? Zirconium. Zirconium.
It's not available. Yeah, you saw the phase 4 trial is there. It will launch next 6 months. So we'll have a good molecule. Let us see how it is. But it's expensive because it's one of the multinationals are bringing in, and of course later on it will come down.
Sir,
Cannot keep this because you know in heart failure patients at least this
sir, use the mic.
hydrolazine and isosorbide dinitrate is not a alternative for this RAASi therapy. We can't give RAASi means we are taking out the benefits from the patient of RAASi therapy. So for CKD, cardiorenal syndrome, diabetics, and heart failure is concerned. All sorts of heart failure. You see, the TopCat trial, Mark Pfeffer told long back in 2014, I think you remember, in Barcelona, ESC, that is very helpful. He, of course, demanded that there is a 15% reduction, but it's not true in mortality. There was no mortality reduction, but there was a little reduction in event rate, and he gave so many implications for it. But we have seen in the subsequent trials that MRA has become a drug of choice in HEP therapy, because for HEP we have got so many. 4 pillars are there. Of course, this MRA is one of them, and we give a big dosage of ARNI therapy and all other things. So ARNI plus MRA, chances of potassium going up is very high, and we have either to reduce at this point of time or totally take it out. And that doesn't give the benefit of RAASi therapy to this group of patients who extremely are needy of this molecule, and unfortunately they cannot take. Yes, gentlemen, you come out your question.
More than 90% are primary and idiopathic hypertension. Each hypertension before giving ACR or ARB.
You saw the ARB, 3% of the population were given ARB, and more than 60% were given AC inhibitors, and 30% in heart failure.
In this case, baseline potassium.
So ARB was not given in a major population. It was mainly AC inhibitor and ARNI. Because, AC inhibitor has got good effect on the mortality and endpoints than ARB. So, data is more with AC inhibitors in the hypertensive group. And in heart failure, ARB is the number 3 choice. In CKD 2. So, nephroprotective action is more with ACEI, more with ARNI than ARB. Though ARB are very helpful, I agree with you. ARB in our population, it's the most effective anti-hypertensive. There are so many things that in China, it's a carcinogenic. Just today morning, I have got the WhatsApp pending. Some very elite lady for her husband has asked, this is the cutting. They have given a paper cutting from some foreign journal, from foreign newspaper, and they are telling, is it safe to take this one? And yes, people are taking in 1,000, and it's a DCGI approved molecule.
Yeah.
My question, when a patient diagnosis, first time diagnosis hypertension, by 3 times measurement of the hypertension in around 40 years or 30 years age, need anti-hypertensive drugs, telmisartan, and as well as baseline potassium measurement.
Anti-hypertensive drugs, see, we give aldactone as a treatment of resistant hypertension. But not always we give this molecule in the treatment of resistant hypertension, because I have been successful. I was also in the guideline committee to include hydralazine, and I think you will agree with me, Vijay, that, and also Nidul and Arindam, that, this molecule with the hydralazine is extremely effective, and if you really want to control the resistant hypertension, after the number 3, 4th I should come hydralazine in our country. At least my experience is that spironolactone is not that effective. It increases the potassium, because already you are giving 80, 120 or 160 milligram in extreme cases of telmisartan, and you are adding on top of that this molecule, and chlorthalidone alone cannot prevent the hyperkalemia ensuing from those 2 molecules.
So thank you, Dhimanda. We badly need this molecule because, the FSS trial, which was launched in 2003, and in 24 uses of MRA is only 50%.
Absolutely.
In Paradise-MI, MRA was used only in 42%.
Yeah.
Just because of the fear of the hyperkalemia, unless you have these molecule, these foundational therapies of heart failure cannot be used to the target. So thank you once again.
Thank you. Thank you very much.
Actually, the main issue is that actually we should not deprive our cardiorenal patients to get the maximum dose of ACR. It's a very important point. And just I would like to share one study, that was a Japanese study, that was a head-on comparison between zirconium cyclosilicate with the calcium polystyrene sulfate, and they showed that zirconium is more effective in CKD patients in reducing acute hyperkalemia. So they published the paper in 2022. Thanks. Thank you all for your presentation. Thank you, sir.
Thank you, Speaker. Thank you, Chairperson, it's time to facilitate our eminent speaker and Chairperson Dr. Arindam Lashkar. I'd like to request our two founder member, Dr. Pandey and Dr. Mridul Bera, to please felicitate them. Thank you, Speaker. Thank you, Chairperson.